Hello, hi everyone, and good evening. A very warm welcome to tonight's pre-conference webinar by In Supply Health on Policy to Practice, enabling community pharmacists to deliver family planning services in Kenya. Yes, as we wait for more people to join, let's do a quick vibe check on the chat. Where are you joining us from? Is it as cold as it is on my end? Maybe if you could please type in on the chat, let us engage. How was your day? Are you still surviving on caffeine like myself? We'll just give a few minutes for a few more individuals to join. I hope my audio is audible. Shout out to you, Roslyn from Nairobi. And wow, Dennis is in Mexico ready to face South Africa. Interesting. If there's anyone who supports South Africa, maybe you can also comment. Ibrahim from Wajir, karibu sana. Susan Jogu and Faith from Nairobi. We have Juma from Nairobi also. Where are you tuning us from? We already have Angelica from Ruiru, Richard from Eldoret, Tabitha from Nairobi. Welcome. Josephat from Mandera. A few AI assistants have also joined us. I see some of us are embracing technology, which is amazing. Steve, Elixium Pharmacy in Mwehoko. Karibu sana. Okuta from Suba South. Welcome very much. Good evening, Miriam, to you too. Daniel from Nairobi. How are your energy levels this evening? Linus from Kitale cheering for South Africa. Yes. Our job in the World Cup finished last time. Now we are just against Portugal, supporting all the other teams. Karibu Frida from Nairobi. John from Nairobi. Is everyone from Nairobi tonight? Oh, Pemur from West Pokot. I wonder how it is there. Is it as hot, cold? Never been there. If you joined us last week, welcome back. This last week, we kicked things off in this webinar series by looking at the bigger picture of transforming access, how community pharmacies are securing Kenya's family planning future. We saw the potential that was there in community pharmacies, and tonight we are taking the next logical step, moving from policy to practice, to look at exactly how can we make these things happen on the ground. They say kwa ground vitu ni different. It's great to see the energy in the room. Keep the comments coming. Thank you so much to everyone who is engaging with us. And maybe at this point, I see we have quite a good number. Oh, Abdishakur from Burkina Faso. Interesting. What language do they speak in Burkina Faso, Abdishakur? Um, as we continue to engage, allow me to just briefly share a few ground rules. You will be muted during the entire course of this session. We encourage you to use the chat section for interaction, but if you have any questions, please use the Q&A tab. These questions will be addressed by the presenters at the end of the session. The event is open to all PSK members. The session is recorded and will be made available on our YouTube page. It is CPD accredited. However, I see many of you commenting that it's not on the PPB portal. Yes, it's not. But once it's up, we shall update you. You'll be able to subscribe and claim your tokens. And then the minimum requirement for attendance is at least 75%. And I see we're already almost at 10 minutes in. Our moderator for tonight will be Dr. Sheila. I have the pleasure of inviting her. She's a powerhouse in our profession, and she'll be guiding us through this discussion. Sheila, the virtual floor is yours. Allow me to stop sharing my screen. Karibu sana.
Thank you, Miles. Thank you, Dr. Miles, for the introduction. I don't think anyone has ever called me a powerhouse before. So,
You are.
karibuni, everyone. Thank you. Karibuni. Welcome to everyone to this webinar today. We are happy to be back here again to just build up on the conversation we had last week and now show you how policy to practice has been enabling community pharmacists to deliver family planning services in Kenya. The work that we've been able to do, the collaborative approach that we've taken together with the Ministry of Health. And we are privileged to have two very good speakers today. We have Mr. Mbule from the Ministry of Health. We have Dr. Isaac from URADCA, the Urban Research Center, who are our partners in the project. So allow me to just show you our agenda. So today we will go through the MOH perspective, why policy is important, why the community pharmacy is also important, why now, and why this conversation is important. Then we'll go through the enabling policy environment. So what policies have enabled community pharmacists to be able to offer these family planning services? What does that engagement look like moving forward? Then we'll have a chance to also just do an Q&A session, but also as we continue throughout the session, in case you have a question, please put it in the Q&A. You could also put it in the chat. I'll be monitoring the same to be able to have our speakers address them towards the end of the session. Then we'll have a quick feedback mentee at the end just for us to engage and get feedback from the two sessions that we've been able to present to you, just to get your feedback on whether you feel the conversation is timely, is it relevant, is it something you are vibing to and engaging with. So we hope to stick with you till the end of our webinar and karibuni sana. I want to take this opportunity to welcome our first speaker, Mr. Ambula Mohammed from the Ministry of Health. He is currently working as a senior program officer at the Ministry of Health under the Division of Reproductive, Maternal, Newborn and Child and Adolescent Health, DIRAMCA, and he will be taking the floor for the first session. Karibu sana, Mr. Ambule.
Yeah, thank you, Sheila. I don't know whether I'm audible to start with.
Yes, you are.
Thank you. Thank you. Thank you for bringing us together. Thank you for this evening's virtual meeting. As has been explained, I work for the Ministry of Health. My name again is Hambule Mohammed, Senior Programs Officer and Epidemiologist at the Reproductive Maternal, Newborn, Child and Adolescent Division of the Ministry of Health, Kenya. I can see we have a mix of participants far and wide. Now, yes, we want to have this discussion of why Pharmacy Channel and what it has done so far for our country, Kenya. And to start with, I just want to give a background. About 7 or so years ago, this country looked at the service delivery environment against the backdrop of dwindling donor funds for family planning programming and stakeholders, including the Ministry of Health as a steward, brought together several interventions, which included the utilization of the already existing sustainability mechanisms. And this has largely come through the recognition of the private sector as a major player in enabling access to what otherwise the public sector may not have the resources adequate to cover everyone. And so I want to probably take you through 2 slides and then go back to my oral delivery. So if you're ready, Sheila, please bring up the 2 slides that we have. And so the Ministry of Health has the mandate to coordinate all health sector players, including the private, the not-for-profit, faith-based, and the CSOs, majorly our implementing partners. And as a country, Kenya is a signatory to the FP 2030 commitments and the Sustainable Development Goals, specifically SDG number 3, which spells out what we need to do by 2030. So we are looking at ensuring healthy lives and promote well-being for all our citizens and those who live in the country. Again, we anchor all our efforts on our Constitution of Kenya 2010, which spells out, of course, that health is a right. Every person has a right to the highest attainable standard of health. And the good part is including reproductive health. Remember, family planning is anchored and housed within reproductive health services. Now, just to give you a highlight on our performance, according to KDHS 2022, our modern contraceptive prevalence stands at 57, and we want to move this through our FP 2030 commitments to 64 by 2030. We've made progress all along since 2008, and we really want to, again, continue to make progress towards achieving the 64%. However, within all these efforts, we've also seen that our unmet need is significantly high, standing at 14%, according to KDHS, our Kenya Demographic Health Survey of 2022. So that means 14% of all our married women are not accessing family planning services or birth spacing services or contraception services, depending on the audience we are talking to, due to one or more reasons. In addition, Kenya has a triple burden of non-communicable diseases, specifically communicable diseases, and the triple threat stands in the way of HIV, and unplanned pregnancies or teenage pregnancies, and unmet need. And so we have really to focus our energies and our resources and our investment to interventions that can help us, improve on those indicators. Our health system gaps still remain, just like any other country, and they include the workforce shortages, personnel, skills. We also have challenges around infrastructure, inadequate health financing, specifically domestic financing, and lack of quality and timely health data for decision making. Of course, we have a very robust health information system. However, the quality of the data is something we need to work on. Again, to mitigate these challenges, the Ministry of Health, through the Division of Reproductive, Maternal, newborn child and adolescent health has developed policies, very vibrant ones, very supportive ones, guidelines and even strategies and training materials that, of course, will strengthen the health sector. And lastly, these policies, as much as they've been developed, implementation of these policies have always been a challenge, either because of resources that should follow policy development or the other factors, including goodwills from leadership, political leaders, and sometimes we also have cultural and religious barriers to achieving what we need to achieve. Next slide, please. And so why we are having this meeting is largely to be able to bring forward the policies to the stakeholders to understand that the policy environment is supportive. And so the private sector may not be aware of the many, many public health policies that are in place, including those that support reproductive health services. And so this evening, we really want to take you through some of those enabling policy environments that are in place and can be utilized by both the private sector and the public sector. And so I should thank our partners, Euradica and In Supply Health, who have brought us together. And they have spearheaded the crafting and the validation and the finalization of some of these dissemination materials that target to disseminate existing reproductive health policies. And we also have our regulatory body, PPB, and our associations, and I should thank all of them who probably have done one or two things in supporting us realize this milestone. And so I will stop sharing the screen for now and just make a few remarks and allow Dr. Malonza, my colleague, to probably expound more on some of the policies that we have and the briefs that have come out of the validation meeting that we've had a few, just 1 or 2 weeks ago. Before Dr. Malonza comes, I want to talk about, just mention some of those policy documents. They could be policies, strategies, guidelines, and some of them are training materials. Much of it will be expounded and explained by Dr. Malonza, but remember the guiding principle is usually the highest document in the land that gives direction. And we have the National Reproductive Health Policy 2022 to 2032, which largely recommends provision of confidential quality FP info and services, and of course, followed by reporting of those services by the pharmacy fraternity. And here we are talking about pharmacists and pharmaceutical technologists in this country in providing reproductive health services. We also have our new baby on the block, which is the 7th edition National Family Planning Guidelines, which is as new as last year, 2025. And this explains a little more on the roles of every player, every service provider, including the pharmaceutical providers. We also have the adolescent and youth sexual reproductive health policy, which was done in 2015. And it also talks about the personnel that will help or support our young people deliver the services confidentially, privately, discreetly, and eventually, of course, report the service data that we require for decision making. We also have the national guidelines for self-care. Remember, Kenya has adopted the self-injection as part of its self-care interventions. And we are looking at self-injection as an intervention for self-care. We also have the National Reproductive Health Commodity Strategy. Remember, our pharmacy personnel, whether a pharmacist or a pharmaceutical technologist, countrywide are charged with the responsibilities of, managing our health products and technologies, including family planning products. And this usually involves policies, regarding commodity management. We also have biannual forecasting and supply plan, committees meetings. We also have procurement.
Seems we lost Mr. Ambula. Miles, confirm you can hear me.
I think I can't hear.
Right, let me reach out. Apologies. He dropped off, but he's resuming. I'd request if we could continue with the conversation. I can see guys are signaling that they lost the sound. Yes, the speaker is coming back. But in case you have any questions, please start typing them in the chat. Then we'll be able to address as we continue with the presentation. Let's give the presenter 2 minutes to rejoin, and then we can continue with the session. Apologies. For those inquiring, the event will be on the PPB portal as from tomorrow. So you could subscribe as from tomorrow. An email reminder will also be shared so that you could be able to subscribe to the event once it's made live on the PPB portal. Apologies again. We are just waiting for Mr. Ambule to rejoin the call. He has dropped off, but he's going to be back. I hope you can be able to hear me. As we wait for him to rejoin, please share your questions on the chat or on the Q&A session regarding the presentation that has just been done. As we continue, as we give him 1 minute to be able to rejoin us so that he can finish up on his presentation, then I'll be able to introduce the next presenter, Dr. Isaac, so that he can be able to take us through the session on the various policies and the briefs so that then we can further be able to understand how the policy is shaping the implementation of family planning within the community pharmacy space. So again, please just share your questions. Just as a reminder, the webinar will be live on the PPP portal by tomorrow. An email will also be shared on the same so that then you can be able to subscribe to be able to get your CPD points. Thank you. Okay, thank you for those who are already sharing in the questions. Thank you, Johanna. We'll be able to address how you can find family planning recording tools as we near towards the end of the session. Thank you also for those who have already started sharing questions on the Q&A. We'll be able to address the same as we continue with the session. Please keep the questions coming as we also give Mr. Mbule 1 more minute to join. All right. So I would like for us to continue with our session. So Mr. Hambule has done a brief overview of the policy frameworks and how they're shaping the implementation. Allow me to introduce our next speaker, Dr. Isaac Malonza, who is the CEO of URADCA, and he'll be able to go a bit more deeper into the policy briefs and how the environment is aligning with the MOH's private sector strategy for us to just be able to understand better how the community pharmacy space is being supported to implement family planning services. Karibu sana, Dr. Malonza. Allow me to stop sharing my screen so that you can share your presentation.
Thank you very much, Sheila. Good evening, everyone who is on this webinar. Let me try to bring my face so that people might see me. I hope you can see me. Let me bring up my slides. Okay.
Yes, Dr. Malonza, as you bring up your slides.
Oh, good. You are back. So you can just finish your presentation.
I am finally back, but I am left with not much. Sorry for the hitch. Yeah, I probably might have gone into some network issues. But I had talked about the National Hormonal IUD and DMPS training packages for pharmaceutical providers. We also have, of course, the Kenya Health Policy, which supports collaboration of the public and the private sector. And I want to talk about what gave birth to all this cascade of interventions is the total market approach strategy of 2020 to 2025, which of course brings together the public, private, CSOs, FBOs to support the achievement of a balanced family planning market. And family planning market, of course, is in the sense of a public sector supporting those who cannot afford, or those in the lowest, wealth quintile, and the rest who can afford probably are also left to, reach out to the private sector and pay through insurances or even out of pocket because they are able to afford. That is total market approach. And lastly, we have the training package for pharmaceutical providers, and this provides the roles of trained pharmacists, pharmaceutical personnel in the provision of family planning, information, services, and referrals. Remember again, Kenya went ahead to develop a face-to-face training package, which we have used over the years. And currently, we have also developed an online approach in which pharmaceutical providers who are interested and who have also been vetted and, with a criteria to ensure that they are actually people who are recognized by the system and licensed to practice can enroll online approach. And usually the online approach may not end up purely online, and we call it a hybrid kind of an approach, because eventually we will then have some skills building done to the providers who have enrolled at the end of a period of about 3 weeks. And so that is the much we have in terms of the Ministry of Health to have opened up this environment, this policy, regulatory, and even guidelines and strategies and training materials to be able to support the pharmacy sector to also play a part in increasing access to family planning services. I'll stop at that and probably hand over to Dr. Malonza to continue. Thank you very much for the time.
Thank you very much, Mr. Hambule, for your presentation, and sorry for the network challenges. Just confirming that people can see my screen. Sheila, can you say yes?
Yes, Malonza, I can see where I am.
You can see my screen? Okay, good. Okay, so I just wanted to start my presentation by introducing myself and my organization. I'm Dr. Isaac Malonza, as I have been introduced. I'm the CEO and Technical Director at Uradica, standing for Urban Research and Development Center for Africa. We are a Kenyan public health research organization based in Nairobi and working in Kenya and also in the Eastern African region. We are 30 years old this year, and we envision a world where no one dies from preventable diseases and avoidable ill health. Our mission is to improve the health and well-being of African populations through cutting-edge research. We generate evidence that supports policy review and policy development. And also, we use our research to strengthen health programs and to be able to introduce and scale up health innovations. Our core competencies are in 6 areas. We do research so that we can use advocacy for policy change. We are very heavy on implementation research. And also we conduct population-based surveys. We review policies and help the ministry to update, disseminate, and make sure that they are used. We also specialized in monitoring, evaluation, accountability, and learning. And we also develop programs and help with program management. So those are our core competencies. We are very excited to be partnering with the Ministry of Health, with the Pharmacy and Poison Board, as well as In Supply Health to support the pharmacy channel in a number of areas. One of them is on policy dissemination that we are talking about today. And the main idea, as has been explained, is to make sure that pharmacy practitioners are aware of the policies that the government has developed that help you to implement quality family planning services, but also to be able to share policies that help the pharmacy channel with the services that you are offering, and also how the pharmacy channel links more broadly to the other health sector components. The other area that we are working with the Pharmacy and Poison Board, as well as In Supply Health, is we've just conducted a national survey of good pharmacy practice in Kenya. And some of you, I'm sure, may have participated in that survey. It was countrywide. And we recently also conducted a formative assessment among pharmacy practitioners as well as family planning clients to explore whether we should, as a country, offer contraceptive implants at pharmacy. And so you'll be hearing more about this work as we move along. But I wanted to mention it so that you know the work that Uradica is performing in this space. And at this point, as the CEO and Technical Director of Uradica, I really want to thank pharmacists and pharmaceutical technologies who have been kind enough to participate in our studies and accepted to be interviewed, to provide informed consent, and more importantly, to share insights that we will be able to use to feed into the work that the Pharmacy and Poison Board is doing, as well as the Ministry of Health in strengthening the pharmacy channel. So I just wanted to make sure that you can, it goes in record that we are very thankful for many of you who are participating in our studies. So coming back to policy dissemination, so Mr. Ambule has done a great job summarizing some of the key policies that have been developed. Of course, we have a lot of health policies, but what we have done over the last 6 months to 1 year was to identify those key policies that are directly related to the work of the pharmacy practitioners. And so I've listed 9 of these documents that we have worked on in terms of summarizing the content, preparing what we call policy dissemination briefs, and more recently, preparing dissemination slides that we can be able to use in sharing the information. We have also ensured with the... Yes?
We can't see your slides. We can see you, but we can't see the slides.
Oh, okay. Just a second. I don't know how I lost them. Mr. Ambule had confirmed seeing. Just a second. I guess you can see now.
Yes, now they are visible.
Maybe they were not moving. Is it moving on the screen?
Yes, they are.
Oh, they are moving now. Okay. So if they get stuck, I will just alert me so that I can make sure that they are moving. Yes, thank you. So we, as I was saying, we have identified 9 policies, guidelines, or training packages that are relevant to strengthening the work of the pharmacy practitioners, more specifically related to providing quality family planning services. And these are the ones that we are highlighting here, 9 of them, starting with the Kenya Health Policy. There is the National Reproductive Health Policy. There is the National Adolescent Sexual Reproductive Health Policy. There is the Reproductive Health Commodity Security Strategy. And there is the Total Market Approach. And in fact, in one of the PSK webinars, I think in 2024 or last year, we actually disseminated this policy in one of your webinars, the Total Market Approach. So some of you may have been in that webinar. And there is the new self-care guideline in reproductive health. And more importantly and exciting, the newest version of the National Family Planning Guidelines, the 7th edition, that came out towards the end of last year. And then on my right side, you can see those 2 training packages that we would like to highlight. One focused on training pharmacy practitioners on quality family planning services, as well as an orientation package for offering training on hormonal IUD, as well as DMPA-SC. And I'll be going into some detail on some of these. At the bottom of this slide, I am sharing a link to a website, to the Ministry of Health Division of RAMCA, where they have actually uploaded these policy documents as well as other documents. So you'll be able to get this link and download some of these policies, guidelines, training packages in full from those. But also, in working within Supply Health, we will and PSK, we will make sure that you will be able to access the actual policy briefs that are 1 to 2 pages, so that you can quickly orient yourself. And then if you are interested in getting more information related to a document, then you can come to this repository to download the full package. But we know that some of these policies are very large, and many of you are quite busy with your work, so you may not be able to find time to read all these big documents. And hence the work that we have done in summarizing them for you and bringing out the key issues that you need to know in strengthening your work. So we have the briefs in PDF, 2-pager briefs in PDF, and then we have slides that can be used for dissemination. And so at this juncture, let's see whether the slides move. They don't like to move. Okay. Are they moving on your side, Sheila?
Yes.
Okay. All right. So in the interest of time, I decided to go into some depth with 3 of these documents. I'll start with the 7th edition of the National Family Planning Guidelines for Healthcare Providers. And then I look at the 2 training packages and also highlight some of these trainings that are now available for pharmacy practitioners to be able to access. And some of you may have already been trained on using some of these packages. If you have been trained, you can just type on the chat so that we know who has been trained, even as we continue with our discussion. Okay, so I'm going to bring up the 7th edition so that we can do some deep dive into it. Sheila, confirm you can see the document. Sheila, I'm on
Not
you.
yet. Not yet.
Not yet. Oh.
Yeah,
Okay.
not yet. Not yet.
Not yet. Okay, let me see again. Okay. Any hope? Can you see it?
Yes, now
we
we
can
can
now
see the
see it,
slides.
Doctor.
Is it visible now?
We can see it now.
Okay. Yeah. All right. So you can see the actual picture of this guideline is actually on the left side of the screen. This is how the cover page looks like. When you actually download it from the MOH website, or when you actually get the actual document, this is how it will look like. And this was released in 2025. There was a previous 6th edition that was there from 2018, which was then updated to the 7th edition. Okay, so moving forward, on my right of this slide, you can see the policy dissemination brief that we have been able to summarize into 2 pages. So this is how it will look like on my right. So we just wanted you to have a feel of how this looks like. So it's 1 page, but printed on both sides when you get the briefs to make it easy for you to get the key components. But let's go through what key highlights of the 7th edition. So the overall goal is really to provide standards that guide healthcare providers in delivering comprehensive and quality family planning services. Okay, and there were some key innovations that were been highlighted in the 7th edition that were not there in the previous guideline. And this is on counseling, and also on providing quality information for decision making. So these are some of the key areas that have been highlighted. So moving forward, I'm very excited to share this chart. Can somebody confirm we are still seeing the slides? Ambule, you can see?
Yes, I do. Thanks.
Perfect. Yeah, so the 7th edition has this chart that we like very much because it summarizes the products and family planning services that different medical personnel can offer or are approved or authorized to offer. So on top row, you will find the different methods listed there. So from male condom on the second column, female condom, all the way up to the last column where we have female and male VSC. These are some of the, sorry, some interruption on my phone. So this is the first row highlights the different family planning methods or products or services, and on the roles, the following roles below show you the different medical cadres. So medical doctors, nurse, midwife, clinical officer, community-based distributors, you have community health assistants, and at the bottom is where we have the pharmacists and the farm techs. So I would like you to focus more on the column, and then you focus on the last row where the pharmacists and farm techs are listed. So starting with male condom, you can see you are authorized to cancel and actually provide there in your facility. As well as female condoms, we are also authorized to cancel and provide. And where provide is written, there is an asterisk, and at the bottom of this chart, it says only if specifically trained to do so. So where there is that asterisk, it means you can only provide if you have already been trained and certified by the ministry. And that's why there are those training packages that I'll be talking about to support you in that. Lactation or amenorrhea method LAM, you can see you are only authorized to cancel. And then for pills, both COC and POPs, you can cancel and you can provide, and this you have been doing in your pharmacies. When it comes to injectables, we have the DMPA IM as well as DMPA AC subcutaneous. So this is where you can cancel, you can dispense, but you can only provide if, again, you have been trained and certified, especially the DMPA AC one, which the pharmacy practitioners have been authorized to provide once they have been trained and certified. And when it comes to IUCD, the intrauterine devices, contraceptive devices, these ones you cancel and you refer. When it comes to contraceptive implants, here you cancel and refer. And as I have said, we are jointly conducting a collaborative study to explore whether in future, if the data supports this, that implants could be provided at the pharmacy channel, but that will be in future, once studies have been done to confirm that this is safe, acceptable, and feasible in our setup. So stay tuned on that. So when you get this brief or this policy, please feel free to use this chat, because this is where it empowers you to make sure that you are practicing based on your scope of work and you are offering the method based on what you have been authorized to perform. So we like this chat very much, and it was actually there in the 6th edition and retained and updated here in the 7th edition. So that is all I would like to say about this specific guideline. And in the interest of time, I'll move to another one to save my time. So let me go to the hormonal. Okay, I hope you can see my screen again. Somebody
Yes.
shout yes. Good. Okay, so this is the Kenya National IUD, hormonal IUD, as well as DMPA-AC orientation package. And I'll go here. Yeah, so the objectives of this package is to build a provider capacity to be able to offer hormonal IUD as well as DMPA-AC counseling and service delivery, support DMPA-AC self-injection rollout, and strengthen reporting, logistics, and the pharmaceutical systems. And here we would like to really emphasize self-injection for DMPA-AC. So the role of the medical practitioners, including pharmacy practitioners, is to be able to train women and girls appropriately to use DMPA-AC for self-injection. And then also to create demand for these services. So these are some of the things that have been addressed by this package and this training. So it's a 3-day training package. It has 3 packages. There is a training, there is the trainer's manual, which the trainers use. There is the participants manual that the participants use, and then there is a reference manual. So usually there are 3 documents that are used for these trainings. This is a standard that is used by the Ministry of Health when they develop training packages or training curricula. So for this training, it's a 3-day training. It combines classroom learning as well as clinical practice, and also it has supervised sessions. It provides guidance on how you document the service, how you report it, and also how you are able to monitor for pharmacovigilance and also report for it, and also the demand creation activities that you can be able to undertake as a pharmacy practitioner. And so, as I've said, we have the participants manual, facilitators manual, and there are also job aids and checklists that can be used, including mentorship logbooks and evaluation tools. I saw on the chat that somebody was asking, where can we get reporting tools and also evaluation tools? And we'll be able to link you to these documents. So in terms of training eligibility, looking at the last bottom, you can see pharmacists and pharmaceutical technologists are eligible for this training, specifically to be able to counsel and refer clients for hormonal IUD, but be able to counsel and provide DMPSC, including training for self-care. And also to be able to dispense. So these are the key areas that this training package is covering. And before I forget, on my right side, you can see the policy dissemination brief or the orientation package brief that we have been able to create to accompany this. Moving on, what are some of the things that you will get after this training in terms of training motivation? You'll be able to get a certificate from the Ministry of Health for completion. You will get accredited and enter into the list of pharmacy personnel who are trained to provide DMPA-SC. You will be able to receive CPD points through this training. And then, of course, you will have the skills, the knowledge, and the capacity to offer an expanded method choice in your facilities. Again, on this page, we are showing the last page of the brief that we have been able to create. So I'll stop here on this and then highlight the next brief before my time runs out. Okay, quickly. The last one, I would like to just a second to pick it up. Yes. Can somebody shout that you can see it?
Yes.
Perfect. Yeah, so this is the one that actually we prefer that pharmaceutical personnel go through before they do the DMP orientation, because this is a broader family planning training package that was already developed in 2019 to empower you to offer the expanded method mix based on the family planning guidelines that we talked about. And again, you can see how the packages look like. The participants manual, the trainers manual are given there for you to see how they look like. The aim of this package is to equip and empower you with the knowledge and skills to be able to offer an expanded quality family planning service, and specifically expand access to family planning services, including the injectables and specifically DMPA-SC, and also to be able to improve the quality of FP services, including counseling. Quality of counseling has been an issue, and through this training, you are able to get the knowledge and skills on how to effectively counsel clients on various methods. So these are the 3 training packages that we have highlighted, and it is the same structure as I said, for MOH approved training packages or curricula. The ministry prefers to have the trainers manual, the participants one, and sometimes a reference manual, or we have logbooks where appropriate. Like in this case, we have participant logbook so that we can be able to track during practicum before we certify you that you have undertaken enough procedures confirm that you are competent. The package has different chapters, and you can see some of them. You can see FP counseling is highlighted there. Medical eligibility criteria for various family planning methods, very important. This is developed by the World Health Organization and updated from time to time. So this is covered. And of course, the package covers the various contraceptive methods and specifically the ones that the pharmacy personnel are allowed to provide, including documentation. And this is an area that we cannot overemphasize that if you are offering family planning services, we would like documentation. The ministry would like you to report. And so that data becomes integrated with the rest of the national level data to empower decision making. So that's very important. But this training is able to assist with that. It also covers pharmacovigilance, which is very important in monitoring and tracking adverse drug reactions or commodity side effects. So this is very important training. So the package recognizes your key role, and I thought I would highlight that in being able to provide discrete and accessible family planning services in your facilities, being able to educate clients and counsel them on the different methods. The standard for family planning is we are supposed to counsel clients on all methods, and then we go deeper on the method that they have chosen. So this training empowers you to do that. And it also helps us to reduce stigma, especially among youth. And we know that a lot of youth would like to receive services through the chemists and drugstores. And this is an opportunity for us to be able to provide knowledge, education, counseling to the youth on this method. So being empowered to do that is very important. And also, we would like to emphasize referral. So if you have clients who require methods that you are not authorized to provide, we want you to be able to link with the nearest public health facilities where family planning clinics are based. And we are emphasizing that linkage and so that you can be able to refer these clients to those facilities, not only public, but also to private clinics that may be available, offering methods that you are not authorized to provide or to offer. So that linkage is very important. We are also emphasizing that pharmacies actually link up with community-based providers in your area so that they can help you with demand creation as well as linkage to public and private hospitals and facilities in your locality. And then the whole issue of timely submission of data cannot be overemphasized. Again, this is important. Whenever you go through these trainings, you will get a certificate, you will be accredited, and your name will be inserted into a database. You'll get CPD points. But in fact, more exciting is that In Supply Health and the ministry have been working on a logo, a branding for your pharmacy so that it can show that you are actually certified to offer the expanded family planning services. So stay tuned, and maybe Sheila from In Supply Health, during your remarks, you may want to talk about that branding that trained pharmacists should be able to access to show that you can offer this. So we hope that branding, once people know it, might be able to draw clients to your facilities to receive those services. So I'll stop there. In the interest of time, we could not disseminate all the policies in one go. But I think those three, at least, that we could go into some depth, will help you to get a feel of what is available, and more importantly, for you to be able to access the briefs and the rest and the full policy documents through the MOH repository website. So I'll stop there and hand over back to Sheila.
Thank you so much, Dr. Malonza. Thank you so much, Mr. Ambule, for the wonderful session that you've taken us through. I hope it has been a learning experience. I hope we've learned quite a lot and picked up a lot as we continue to implement within our different spaces. I think we can dive right into the Q&A. I see there are a couple of questions that have come in. So I'll start off with the first question. A participant is asking, which is the most preferable family planning method, as a disadvantage of long-term contraception is having many side effects leading to the termination of the family planning method before the required period. Mr. Mbula, would you like to tackle that question?
Yeah, please come again. I think the question is not very clear.
So the
Sheila?
participant is asking, which is the most preferable family planning method, as a disadvantage of long-term contraception is having many side effects, which eventually leads to termination of the family planning method before the required period.
Yeah, great. Thank you very much. Again, we must all understand that contraceptive methods cannot be prescribed. And so that then again leads us to understanding that there is no one shoe fits it all for contraceptives. It depends with the individual. And remember, we have also the medical eligibility criteria that usually pegs its recommendation for the best method, depending on the existing medical conditions or comorbidities and sometimes characteristics of an individual. So it is not proper to say this method is the best, because it's dependent on the individual, and that's why providers must be trained to identify which method is best suited for individuals. If it's given haphazardly, obviously discontinuation rates are very high because you've not checked the background of that client, conditions, characteristics that may, may impede the use of certain methods. So all contraceptive methods are good, but they must be against the backdrop of the medical eligibility criteria that we have. And the training empowers you to identify those medical conditions and characteristics that you should consider when you are probably guiding a client towards decision making. Over to you, Sheila.
Thank you, Mr. Mbule.
Maybe I can just add to Sheila, if you can allow me, I can add to what Mr. Ambule has said. Yeah, I agree with that. Just to add that one from my own experience, one of the challenges clients using family planning methods may face is if they don't understand the side effects that are linked to their method. And also for some of the side effects, they occur early when the method is being used, and then over time they disappear. So we are mandated to counsel the clients on these side effects so that they anticipate them if they occur. And if they occur, they should be able to know that some of them actually disappear after a period of time, especially with the injectables, where early on in the first few weeks, some of the side effects come in, but they wane over time. So if you counsel your client very well on the side effects, that helps. But also there's this tendency among clients, when they hear that there are side effects, they think every woman must get all the side effects in the book. So again, that's part of the counseling that we need to offer clients, so that once they are informed, they will be able to deal with side effects that occur, so that they don't rush to discontinue a method just because a side effect are started. So I thought I would just add that to what Mr. Mbule had said. Thank you.
Yeah, thank you very much, Dr. Malonza. Again, remember, family planning in the pharmacy setup, for those who have not been trained, they have always been dispensed, not considering the client's characteristics. And family planning is not a treatment where you prescribe. So you always need to do counseling. And if counseling is done so well to the client, for them to understand the side effects that are associated with the method, that sometimes are mild and can go away soon, they are able to continue a lot more, and discontinuation rates can be managed effectively. Thank you. Sheila?
Thank you, Mr. Mbula, and thank you, Dr. Malonza, for that elaborative response. We have another question that a participant is asking. I have confirmed that Kenya's total fertility rate has decreased from 4.9 in 2003 to 3.4 in 2022 and projected at less than 3.1 in 2026. Given this tremendous drop, what are the figures on the unmet need based on? And what are the programs targeting increased uptake meant to achieve? Mr. Mbula?
Yes, thank you, Sheila. Again, a lot of interventions around bridging the gap of unmet need have to be put in place. Part of it is looking outside the box, from the routine providers to looking at the pharmacy channel, and even the community health based distributors. In Kenya, we have the model of community health promoters, in which they give information and referrals. But in our FP 2030 commitments, we envision by 2030 to reduce our unmet need to below 10 and below. Currently, we stand at 14. And so I am sure probably when measurements are done in the next few years, going into 2030, we would see some of the benefits we will reap from having involved the pharmacy practitioners. In regard to fertility rates, yes, we've made milestones. Since the late 1970s, our fertility rates have ranged from 9 children per woman to now about 4 children. And so, again, going into 2026, we want to see a drop, and our goal is to reach a replacement level. Our replacement level, of course, is about 2.2 TFR, and so we are heading there, albeit very slowly. Thank you. Over to you, Sheila.
Thank you, Mr. Mbula, for that response. There's another.
Maybe Sheila, just to provide more information again. So, I realize people may not know what some of these terminologies are measuring. When we're talking about unmet need, because I think the question was confusing total fertility rate versus unmet need, and asking if the total number of children a woman is having in Kenya is reducing, how come we are having unmet need? But the two things are measuring different things. So just to clarify, TFR is the total number of children that a Kenyan woman has by the time of the survey, that is 2022. But unmet need is asking a different question. If you survey married women, as that's what KDHS 2022 does, is asking, would you like to use a family planning method? They say yes. Are you using one? They say no. So if a married woman would like to use a family planning method, but she's not using one at the time of survey, that's what we call unmet need, because these women have a need for using contraception, but at the time of survey, they are actually not using. And that percentage in 2022 was 14%. And we are hoping this will come down. And there are many factors that can explain why a woman would like to use a method, but she's not using one, either because she's not able to access the method, either the facilities where they are offered is far, or a method of choice is not available, or the commodity is not there. So there are many factors that could explain why at a given time, women and girls who would like to use a method may not be using. And that's the number that we want to reduce as we go to 2030, to reduce that proportion of women wanting to use a method, but they are not using, which is what we call unmet need. So the two things are measuring different things. Thank you.
Thank you, Dr. Malonza. There's another long question here. On DMPA safety, FDA has a conspicuous black label warning on bone mineral density, which the ministry guidelines does not list in the side effects or adverse effects section, adding a section towards the end that minimizes the risk as slight. Do we have pharmacovigilance data for this in our settings? What is a slight framing based on? And then on amenorrhea, the guidelines still frame it as beneficial for some patients. My experience is that it's a cause of alarm in most patients. Do we have data on the proportion of women who have delayed return to fertility after cessation of DMPA? What is the average length of fertility return and those with prolonged delays, more than 6 months, and those with very prolonged, more than a year? Mr. Mbule, maybe you could start. Mr. Mbule?
I'm unable to. Okay, I lost you at some point. But it's a very long question, or many questions in one. But let me handle one, DMPA classification in the medical eligibility criteria. Remember, in the 2015 version of the medical eligibility criteria, WHO gave, if people understand what criteria are, remember medical eligibility criteria has 4 classifications. Criteria number 1, 2, 3, and 4. 1 is good to use, 2 is desirable to use, 3 is not caution, take caution, and 4 is not to use completely. And so by 2015, the WHO medical eligibility criteria prescribed DMPA-SC as having been in category number 1, which did not show any safety concerns. However, after the revelation of the bone density erosion recently, that category has come down to category number 2, means desirable to use. Meaning, if a client is assessed against her characteristics and medical conditions that are existing, and this client is placed in category number 2 under the medical eligibility criteria, it means that the provider needs to find whether there is any other contraceptive method that would place this client in category number 1 rather than 2. So because of the bone density issues, the criteria has been moved down from category number 1 to category number 2. And we have adopted that in the Kenya's version of the medical eligibility criteria. And so we are still consistent with safety issues. The other concern was about return to fertility. Remember, return to fertility for DMPA, SC specifically, not SC, DMPA generally, IM and SC ranges between 6 months to 12 months, meaning there could be a few clients who will be very apprehensive after stopping and with an intention to conceive. 6 months is a long time. And so in our guidelines, what we emphasize is for clients who have been on DMPA for quite a while, whether IM or subcutaneous, and they intend to conceive, they need to stop the use of the injectable a few months, rather about 6 months before. So they need to miss about 2 injections ahead of time, because every injection usually lasts 3 months. And so we've still taken care of the issues regarding return to fertility. I'm not sure whether I captured the other remaining questions. Sheila?
The pharmacovigilance data, there's a question they've asked whether we have pharmacovigilance data regarding the black label warnings in our context as Kenya.
Good. Yes, pharmacovigilance in all our trainings, including the one that was presented by Dr. Malonza in terms of the training package, whether face-to-face or online, there is a whole module on pharmacovigilance, not only for DMPA, but all the methods. However, our pharmacovigilance targets, generally visible ADRs, adverse drug events or reactions. And so we have a portal with PPB, an online portal that usually this is reported. And so pharmacovigilance for us is largely about, visible or reported events. But we haven't really gone deeper to identify issues around return to fertility so that it's reported as part of the routine, adverse drug events. So for now, we report whether there are any reactions, any anomalies that is caused associated with the use of contraceptives. Over to you, Sheila.
Thank you very much, Mr. Mbule. We have one more question. How do we manage bleeding associated with the Femiplan injection? The patient was injected with tranexamic acid, but no positive outcome was reached.
Great. Remember, Dr. Malonza also shared the current 7th edition family planning guidelines 2025. And we have explained heavy menstrual bleeding as probably a part of the side effects to be expected when using contraception, specifically hormonal-based contraceptives, and the management is clearly given in the guidelines. And we usually start with the first line. For the people who usually rush to give tranexamic acid, maybe you have skipped one step. And the management of, enhanced bleeding following contraceptive use is usually starting with brufen, ibuprofen with enhanced dosage, up to 800 milligrams TDS for 5 days or a week at most, because of the gastric erosion we know comes along with the use of brufen. But after that, probably the client then can be referred for gynecological checkup, because bleeding is not only associated with contraception. Heavy menstrual bleeding could be caused by other factors, and so they need to be managed in that manner. But the guidelines usually start with the management in the first line treatment for heavy bleeding, starting with Brufen. Over to you, Sheila.
Thank you very much for answering the questions. I would like for us to now move into a session where we'll do a quick feedback mentee just to engage with the participants, so that then we can just get a chance to, get feedback from the two sessions that we've been able to present to you, and whether or not they've been informative. So I'll request Dr. Miles just to also share the mentee.com link. So please go to mentee.com and you can be able to put in the code 3173648 to be able to join the Mentee. Once you're in, there's a heart at the bottom of the screen. You can be able to just give me a heart, so that then I can know that I have participants engaging with me within the Mentee. So the same has been shared to the chat. I can see one participant has joined. Please keep joining, so that then we can be able to get feedback and also just improve on maybe engagement, even as we continue to structure the trainings for the pharmacy space. Let us know what your thoughts are. We would like to get feedback from you from the two sessions, any areas we may be able to improve on. We are about 600 participants within the call. If we could get to at least 100 would be good, or even 50, so that then we could start the session. So go to www.mentee.com, put in the code 3173648. Once you're in, tap on the heart, so that then I can know we are together. And then I'll be able to move to the next screen. I see we are 30 on the call. If we could get to at least 100, we're about 600 people in the call, so that then I could start off the Mentee, so that then we get feedback on how the session has been. I see a lot of people have registered interest on wanting to be trained on family planning. I think that is one of the goals we were hoping to achieve from these two sessions that we've had, to at least elicit interest, so that you may be able to understand that there's a lot more that pharmacists can be doing within the community pharmacy space, and it's already being done, and there's an environment for you to be able to be supported on the same. So for those who've registered interest, we shall also just be going through PSK, so that then we can be able to, get a conclusive number and details on who is interested in the training, so that and also communication will still be passed through the association for you to be able to sign up when the next training will be announced. I see we are at 64. If we get to 70, then I can start. Thank you for the 40 who've shown me love through the hearts in the Mentee. Thank you for the wonderful feedback you're also sharing on the chat. I'm glad the sessions have been very informative. Thank you, Catherine, for looking forward to the training. We are at 71. Allow me to move to the next. Please continue joining using the www.mentee and put in the code that has been shared on the chat. So allow me to move to the next. So what stood out for you most during the presentations? For those who are able to attend this webinar and the previous webinar, what stood out most for you from the presentations that have been shared by our speakers from last week and this week? So please type it in on your screen and click submit, so that then we can start seeing those responses popping out on the screen, so that then we can see what feedback, the guidelines on family planning. Thank you. What else stood out most for you? Being able to know available resources on family planning. Thank you. The number of existing policies. I didn't know there were that many. Improving access to FP, the guidelines, the sessions were very informative. Thank you for the feedback. Training opportunities, yes, well detailed and elaborate. Almost everything, thank you. The choice of presenters, thank you. Kudos to them also. Please continue typing in, knowing that pharmacists can squarely handle this after appropriate training. I enjoyed the depth and comprehensive nature of the information shared. The eloquence at which the resource was shared was also astounding. Thank you very much. The great opportunity that we have been given and all the support, both from our respective organizations as well as ministry and all can give to this space. Thank you. The space pharmacists are taking up in meeting unmet needs. Thank you very much. Policies for family planning. The webinars were enlightening. The training opportunities again. Guidelines. The presentation. It was helpful to know different ways to manage family planning side effects. Thank you. If I could get to at least 45 responses, at least that's half of the people who've joined, but please keep sharing in your responses. Feedback is very important. It also helps us shape the conversation moving forward so that then we know how much more or how better we can keep improving on giving the services for family planning within the community pharmacy space. All right, 46 responses, informative, the guidelines. Okay, allow me to move to the next. In one word, describe what community pharmacies mean to family planning access in Kenya. In one word, how would you describe what community pharmacies mean to family planning access in Kenya? Safety, very nice. Thank you. Access, a game changer. Reachable. Accessibility, reliable. Accessibility comes in strongly. Safety and access. Convenience. Nice training. Thank you. Convenience, accessibility, and access are strongly standing out. So is safety, so is availability, so is safety and access. Reachable. Oh, there's someone who said bespoke. Very nice. Improved. Timely. Thank you. Confidence. Considerate. Accessible and friendly. Okay. Professionalism. Thank you. I see we have 48 responses, 49 out of 97, 50. Thank you. Awareness. So the keywords that are standing out is accessibility, access, affordable, safety, available, safety and access. Thank you very much for the feedback. Allow me to move to the next one. So before today's session, how familiar were you with the 9 policy briefs that have just been presented? How familiar were you with the 9 policy briefs that were just been presented? This was my first time encountering them. I had seen a few, but not all. I had heard of them, but not read them. I was aware of most of them. It's very nice to see that some of you have actually interacted with them, sorry. A lot of us, it was our first time encountering them. Most of us also had seen a few, but not all of them. Some of us had heard about them, but not read them. I think the majority had seen clearly. Oh, wow. It's good to know that it's not very new, but we hope that you've learned a bit more about the policy environment and the briefs that are shaping this conversation. I have 47 responses. If I could get to 50, we could move to the next. I see 14 are saying this was my first time. 20 had seen a few, but not all. Now you know that there are 9 of them shaping the conversation around family planning. So once we share the link, please go download, take time, read through them, understand them, see the value that they bring to the work that we are trying to achieve in family planning in the community pharmacy space. Allow me to move to the next. Which policy briefs do you feel is most critical for community pharmacy practice right now? So of the 9 that have been shared, which of the briefs do you feel are the most critical for community pharmacy practice right now? It could be the training pharmacists package, could be the national FP guidelines, the 7th edition, or the national reproductive health policy, the total market approach, the self-care and reproductive health, the National Reproductive Health FP Commodity Security Strategy. There's a Kenya National Hormonal IUD and DMPSC Orientation Package. There's the National Adolescent and Reproductive Health Policy. Yeah. I see a lot of you are angling towards the training pharmacists in FP package and the National FP 7th edition guidelines, which heavily states the scope of practice when it comes to what a pharmacist can be able to achieve within the community pharmacy space. What can we be able to do when it comes to FP? How do we better serve our clients within the space once they come for service? How do we cancel? What methods are we able to offer? What methods are we able to initiate them on? What methods are we able to do follow-up and counseling and for referral? Thank you for the feedback. I see 39 out of 100. If we could get to 50 would be good, so that then we could move to the next. Thank you for engaging also in the Menti. So majority of you are angling towards the first 2. And you feel those are the most critical for community pharmacy practice right now. Thank you for the feedback. 41, 42 responses. Thank you. If we could get to 45, I move to the next. Okay. Allow me to move to the next one. What is the biggest barrier preventing community pharmacists from fully implementing the policies that we've been able to discuss today? Is it that there is inadequate training and accreditation? Could it be the commodity supply chain gaps? Is it limited awareness among clients stroke stigma? Is it a lack of designated safe space or infrastructure? Is it because of weak public linkage systems? Which one do you feel is the biggest barrier that is preventing community pharmacists from fully implementing the policies and giving FP services to clients within the community pharmacy space in our country based on the 2 presentations that have been shared? Yeah, I see the one that's coming in strong is inadequate training and accreditation, closely followed by commodity supply chain gaps and limited awareness among clients and stigma also. Okay, awareness is strongly coming back. There's some who are saying weak public-private linkage systems could be the root cause. Others are heavily on regulatory and licensing constraints. But the key one that's really standing out is inadequate training and accreditation. Please continue to give feedback. You could vote through your phones, but then you can be able to see which challenges do you feel we should also address as we continue strengthening the pharmacy channel to be able to continuously offer quality family planning services. Thank you for also those who are responding on the chat. I do appreciate the feedback. Okay, if we got to 40, I move to the next. Seems the 3 main barriers are inadequate training and accreditation, limited awareness among clients and stigma, and commodity supply chain gaps coming in strongly as the key barriers that we need to address. Allow me to move to the next. How can we make it easier for community pharmacies to report family planning data into the KHIS system? So even as we implement the project, even as community pharmacies are strengthened and trained to be able to offer family planning services, how do we also ensure that these indicators are being captured very clearly within the ministry network so that then they also drive informed decision making? Introduce a website for data entry. Thank you. Simple mobile systems with offline versions. Simplifying reporting tools, providing KHIS training, enable mobile data entry, automate submissions, and offer continuous technical support. Mentorship and OJT to community pharmacies due to staff turnover. Have an online system that links all pharmacists giving these services are all integrated. Training is then provided with the reporting tools, providing a link and login credentials, make it meaningful by disseminating findings. Sensitization on timely and accurate reporting, timely reminders of the deadlines, availing simple tools for reporting, mapping them within sub-counties so that they report to sub-county pharmacists. Thank you. Perhaps through PSK as the association, having an online database with personalized accounts to access it, availing MFL codes and accessibility for automated reporting, provide data registers at the distribution point to introduce online data linkage entries. Thank you. Sensitization again is coming in strongly. Android apps for reporting, system and TATs for reporting, interoperability and digital automation, and also streamlining the indicator matrix. Thank you. Providing adequate reporting tools. Creating a spot offline app that reports on real time. Thank you. Please continue sharing your feedback. It's very important as indicators still need to be tracked, given that family planning is a national program within the country. So even as you're giving services within your community pharmacies. Okay, thank you. Allow me to move to the next. Based on high-performing pharmacy insights shared last week, which factor do you think is the most replicable across community pharmacies in Kenya? Is it owner-operator engagement and leadership, strategic location near markets or institutions, digital marketing and social media use, client retention systems, or offering a broad variety of FP methods? Thank you. There's one person who said owner-operator engagement and leadership. Thank you very much. 3 people are also voting on the same. Someone is saying retention systems are the most replicable. Strategic locations near markets and institutions, digital marketing, offering a broad variety of FP methods. The key one is owner-operator engagement and leadership. So a lot of ownership needs to come from the superintendent or the owner of that community pharmacy to ensure that, the pharmacy is delivering the quality services and they're also meeting the high key performing insights which were shared during the webinar presentation last week. Thank you for all those who are voting. Please continue also sharing the feedback within the chat. For those who are not able to join the Menti, if we get to 35, I'll be able to move to the next. So the key thing here is owner, operator, engagement, and leadership, followed by offering a broad variety of FP methods. Client retention systems are also very important. Digital marketing coming in strongly too, and strategic location not being the most replicable, but still considered as a factor. Okay, moving to the next. What one commitment or action are you taking away from the 2 pre-conference webinar sessions that we've had? So we've been able to tell you that, yes, community pharmacists can be able to offer family planning services, and not just offer. You are moving from dispensing to service delivery, and not just any service delivery, but quality family planning service delivery within the space. So, as a community pharmacist or as a pharmacist, what commitment or action are you taking away from the two webinars that we've had? Knowing that you have a policy that is able to back you up when it comes to, giving the service, knowing that you can be able to create a safe space and how within your premise to be able to offer and deliver that service. So what does that look like? What is that one action? I see training is coming on strongly. So you need to get trained first to be able to offer that service. Trainings and get better understanding of existing policies. I commit to pursue adopting continuous professional development. Training is coming in very strongly. Getting trained and accredited, dedication to good pharmacy practice. Thank you for the person who's shared that. Yes, reference books and getting better understanding of the guidelines. So thank you for all those who are also registering that training is needed. So we've been able to digitize the curriculum together with the ministry, together with Mr. Ambule and the ministry team, so that then we can also make this as accessible as possible for all pharmacists who are interested in the training, so that it's a bit more flexible, so that it also ensures that we scale to ensure that more pharmacists are trained to be able to deliver quality family planning. So it's good that most of you are appreciating that the first step would be to first be engaged in a training to be able to understand how to better give the service. And if you would want to learn more about how that structure looks like, we shall also be in the conference collaboratively working with PSK at their booth, and we'll be showcasing how a community pharmacy model safe space would look like. And we'll have community pharmacists, providers who've been trained and have been implementing and giving services for over a year now, so that then you can just be able to speak to them and appreciate how that practice actually looks like. It speaks better when it comes from someone who's been doing the work, so that then you get to just appreciate how they've been able to also structure the practice individually as pharmacists. Leveraging on this opportunity and opening up for more opportunities. Thank you. Allow me to move to, I think it's my last slide. Yes. So would you be interested in the family planning training? Yes, I am a community pharmacist and I am interested. Not really. And no, I am not a community pharmacist, but I am definitely interested in the training. So I know from this webinar, we have a diverse group of people who've joined us, even those from Burkina Faso, who've joined this training. So maybe you could also share the feedback that Kenya has been able to support community pharmacists to offer quality family planning services within the country, and is backed by policy. So thank you for those who are registering their interest. We really do appreciate that this has been a conversation starter, and we hope to continue the same within the conference. We shall also be having a panel session in the conference on Thursday, where we'll also be unpacking how the system end-to-ends look like, and also just getting to hear firsthand from the people who've been implementing. So please, if you're coming to the conference, do not miss the session. We'll be there in the conference, we'll be at the exhibition. You can also come and engage and learn more from us and also from the providers within the space. So thank you for those who've registered interest. Again, come and engage with us during the conference. We look forward to seeing you there, to sharing more and hopefully learning and hopefully sharing more about the work that we've been able to achieve. Asanteni sana. I would like to hand it over back to Miles. Thank you.
Wow, Sheila, that was incredible. Thank you so much for that. It was a very engaging session. At this point, just before we close and wish everyone good night, I would like to just remind everyone that you may be the only one not coming to Mombasa. Our registration will close soon. These are our current rates. Follow us on our social media channels. You'll be able to engage with this. If you need more information, please scan the QR code. Kenya Airways gives you up to 12% discount on the net fares for the travel duration period of the conference, in case you are still making plans. And like Sheila has said, we look forward to engaging with you down at the coast. You'll be able to see the model pharmacy and learn more. Thank you, Sheila. I don't have much, maybe just to remind everyone that you book it through your portal. If you encounter any challenges, please WhatsApp our comms line. And basically, that's it. Thank you, everyone. Follow us on social media. Let's stay connected. Once again, on behalf of the Pharmaceutical Society of Kenya, thank you, Mr. Hambule, for this wonderful, informative session. Thank you, Dr. Isaac Malonza, and our superb moderator, Dr. Sheila. Thank you, everyone. Again, for those who keep asking for CPDs, I reassure you, you will get your CPDs. Once the event is on the portal, probably tomorrow, ensure you are subscribed and you will receive your tokens. Claim them before next week, Thursday. Thank you. That's all. Have a wonderful evening. Good night, everyone.